year of this interesting of innovative retinal session where you have uh, innovators will showcase their videos, which is very small thing can be innovative also. Even those the instrument what you are using day to day can be used in a different way. I think Dr. Sunil is going to show it in that way. So for the introduction, I'm just waiting for our headmasters. Dr. Lalit Verma is here. So Dr. Lingam Gopal will be just joining shortly with us. Sir, please be on chair, sir. Cheers for the headmaster and cheer for the headmaster as well. So I will just, our innovators are there. Do you have the mic here? Do you have the mic here? So till we are waiting for LG sir, maybe just a brief introduction, Dr. Karthikeya. So if you can just for everyone here.
Hello, I'm Dr. Karthikeya Singh. I'm vitreoretina cataract and refractive surgeon in Varanasi. I'm currently practicing in ASG Varanasi and heading the Retina Institute of Kashi there. Thank you, sir.
Welcome to Retinnova. Dr. Sunil is, since the inception of Retinnova is here. Dr. Sunil, if you can just...
I'm Dr. Sunil, practicing vitreoretina from Karnataka. I'm placed at Davangere.
Okay. Dr. Arjun?
Good afternoon, everyone. I'm Arjun. I'm a practicing vitreoretina and cataract surgeon in Vadodara, Gujarat with ASG.
Okay. Dr. Purna?
I'm Dr. Purna Chandra. So, I'm a vitreoretina surgeon. I work in Narayan Netralaya, Bangalore.
Okay. Dr. Santosh is here. Santosh is here. We welcome Dr. Lingam Gopal sir also. He's here. Sir, please be on the chair.
Good afternoon, I'm Dr. Santosh from Narayan Netralaya. I'm a practicing vitreoretina surgeon.
And Dr. Sivadarsan.
Good afternoon, everybody. I'm Dr. Sivadarsan. I'm a VR consultant from Aravind Eye Hospital, Madurai.
Good talk.
Okay. So Dr. Sudipto could not make it because of his prior commitment. So we'll see whether any extra presentation can be done during that time. Dr. Mahit is on the way from the airport. Dr. Ankur is busy in DSTC, so he will be joining us very shortly. So this is again just a short video to stimulate the discussion, and the masters are here to discuss to analyze that situation, analyze that case, and obviously the final opinion from the headmasters. So we'll start first with Dr. Sunil.
I'll just show you a video of various uses of Finis Flex Loop. Can you replay the video? It's not on the screen. I'll be showing the 4 techniques. The first one is a pediatric RD.
So you have to listen to this talk, na? Udhar bhi awaaz aa raha thoda.
Okay.
वो गर्दन ऐसे यहाँ से गर्दन unnatural
Yeah. It's a PVD induction in a pediatric retinal detachment. So the Finis Flex Loop could be a useful tool and simple tool for induction of PVD, especially we know that the posterior hyaloid will be thickly adherent. We can use many tools, but you can use I'm showing the technique of using a Finis Flex Loop for the PVD induction. The most critical is getting an ideal plane, and is a relatively atraumatic instrument, so you can easily go ahead and lift up the hyaloid from around the disc area. So once you get the plane, the PVD induction becomes quite easily. So it's a very challenging to induce PVD induction in any pediatric RD. Once you get a complete plane and remove the PVD induction, the rest of the things becomes quite easy with pediatric RD surgery. Then it is a routine surgery like any other RD surgery. So this is one of the uses of Finis Flex Loop. So staining definitely helps in better identification of the hyaloid. So the next technique I'll be showing after this will be for the subretinal band removal. As we know, we tend to have many retinotomy related complications you can use the finesse flex loops to support the retinotomy to prevent the enlargement of the retinotomy and retinotomy associated bleeds, and it acts as a counter traction also, and you can pull the subretinal band effectively so that it prevents the retinotomy related complications. So this is another use of finesse flex loop. Then you can do a laser using it. This is a case of a recurrent shallow detachment where we did a relaxing retinotomy, RR was done, and once it has been done under PFCL, the laser was done to the RR edges. But as you can see near some of the places, the retina was edematous, it is difficult to do the laser. So what you can do is use a finesse flex loop, press it against the retina, it displaces a little bit fluid, little bit, so that you can do it laser within the area of the finesse flex loop. So the chances of iatrogenic laser induced breaks will be reduced with this maneuver. So remove the PFCL and oil was put, and the post oil removal, this is the picture, well lasered and well edged, the RR edges were well lasered. You can do the ILM peeling without any forceps just by using a finesse flex loop. So the complete ILM peel was done without using any other instrument except the finesse flex loop. This is a post ERM removal. I edited the part of the ERM removal part was removed. Actually ERM was also peeled with the finesse flex loop and then went it with the ILM peel. You can see the clearly stained edges of the ILM, and you can peel it completely with the help of a finesse flex loop. So simple instrument, you can do multiple techniques with this. So you can peel all around. So no use of forceps in this case, just with the loop only you will be able to peel the ILM. Once you have done that, you can use the dye also to see the extent of the peel and if any residual leftover ILM. So it was restained to see how complete was the peel. You can see that there was no residual ILM, the peeling was complete. So these are the simple 3 or 4 techniques one can use these finesse flex loops for the management of different scenarios, case scenarios.
Fantastic. I think this is the new, at least that laser part was absolutely innovative idea. So we'll take no opinion, Dr. Yeah, Dr. Naresh, Dr. Boral.
It's a good one. But for the first technique is what we usually do is we fill the globe with the PFCL.
Yes.
Under PFCL with the finesse loop or with Tanus.
It becomes much more easier.
Much more easier, and there is a third hand to push it down, number one. And number two, my question is, every time are you using a new loop, or because it's just a 4 micron, after the first surgery it's gone. It's not economically
especially
viable
for ILM peels and other things, you need fresh ones.
I know this is the question is coming to you. I knew it. Yes,
the other uses of finesse flex loops, you can just take one retinal graft. In case of failed macular surgery under PFCL, you can move it from the donor area to the macular area.
I didn't take up that video because a 3 minutes edited video.
Another thing in failed macular surgery, if you are doing the free ILM flap, under the PFCL, take the ILM from just beyond ILM peeled area and just move it towards the macular area.
So one thing I liked is in Tata Steel, you add, they say we also make steel. Here say we also remove the ILM. That is the primary aim that it was made. We also remove the ILM. So one particular point I'd like to say, I mean, I showed it today. In myopic patients where the instruments don't reach, the finesse loop can be used. This ILM peeling technique is very elegant in myopic patients where you can just reach the macula. Yeah.
Controlled ILM peeling, which is sometimes become bits, in bits it comes out. Any of you
even if you use a shark skin, which is more expensive than the ILM forceps, it easily, if you take care of it, it easily lasts around 14-15 cases easily. So inducing PVD with or without PFCL, just pinching with the forceps to shark skin, it's very cost effective. That is my opinion.
So I would like to put one question to both of you. So regarding the ILM peeling completely with the finesse loop, it has been shown that if you do a autofluorescence in those kind of cases, there are multiple areas of where you are pushing it, so it does not look that it is atraumatic, but it does not that much of atraumatic in that way. So probably the ILM, whenever ILM peeling forceps probably will be the better option. Your opinion, sir?
See,
As far as the second patient which you showed subretinal, counter traction, I'm not a very big fan of that. I will do that, that noodle technique.
Yeah, bimanual technique, you can use it. So
that works the best because aim is to minimize the trauma. Remember, ILM is a part of retina itself, and like he was saying, if you do multifocal ERG studies in such patients where you scrap, but you have to be cautious that you're doing on the flap, not on the bare, retina. And I still, am a fan of direct pinch and peel technique. That is least traumatic for the retina. But for showing video, it is...
even I do most of the cases pinch and peel, sir. I want to do an alternative technique which can be done with a simple instrument.
And the third technique which was showing fluid, so I will leave that fluid because it will give me more confidence. The first post-op day that fluid is
my only concern was since it's an inferior RR, sir, so I thought of doing a complete laser rather than a...
That's a very innovative thing. But normally I go back and I do active suction from the retinotomy so that becomes dry and then laser uptake is very good.
Sir, a very high myopic patient, I just couldn't reach, and then the finesse loop was the only option, and I could peel the entire, and it gave a very good result. So.
Yes, I agree because it provides additional length to me.
Sir, but one thing is, of course, for PVD induction, yes, finesse loop makes this thing because using the forceps, the pediatric induction becomes very difficult. It starts tearing and sometimes so frustrated that you can use a finesse loop. But for completing of the ILM peel, ILM peeling itself has recorded so much of Danfil, and so moving more that the more of Sanophil will start picking it up. So pinch and peel, of course, if you want to initiate it, finesse loop always makes a work, and as Vishal said, shark skin forceps also has been proved to do that pinch and peel. The less shearing and tearing forces applied while doing the ILM peeling is more applied to that. But completion of the ILM peeling, I think it's little more dramatic, just my suggestion, but I might be wrong. But wonderful uses, as you showed, is the variety of cases.
You can't be so lethargic that you can't take it out and put another instrument. You keep doing.
I would just echo the same statement that it's more important for us to see what is least traumatic to the eye rather than being able to use an instrument to complete the job. Yes, as a technique, it's very useful, especially when they said you cannot reach with the forceps. This is a useful technique because it extends longer. Barring that, a routine ILM peeling, yes, a pinch peel technique, because for simple mechanical reasons, you're not pressing on the underlying structures to lift up the ILM. And if you have difficulty in lifting the ILM, as I suggested, yes, you start with this, but I would use a forceps for that. So last question I would ask you, since you use it extensively, do you have any shares in that company?
No, sir. Some of the things a video made for Rupak, he told some innovative thing you should do it. Okay, sir.
Thank you, Dr. Sunil. We'll move on to Dr. Karthikeya, please.
And again about the usage of the loop and laser within the loop. Not that I want to antagonize every statement you say, but basically even if you don't get a retinal whitening, if you have treated the RPE there, it's likely that adhesion will come, no problem.
Okay, so good afternoon everyone. I'll just show a quick video for PCV bleed, related bleed, massive bleed, named it Nothing Mountain. Yes. So this is the case 1, part 1. Dense fibrinoid-like bleed was there. On B scan, retina was looking stable, some elevation at the posterior pole. You can see multiple PVD induction was done. These breakthrough bleeds sometimes are very thick and adherent to the retina, and you keep on lifting it at different places. And it comes like the clot which you see sometime in a case of endophthalmitis, and this was an amount of clotting which was there subretinal. So in the first stage, I gave subretinal TPA injection. TPA was injected in different places using 41 gauge cannula, and then partial oil fill was done for this patient. And then the second surgery I did phaco-IOL along with SOR, and it was a routine case of phacoemulsification. IOL was placed, and now after removing the oil, what I saw that the pre-TPA, the clot was really big. Now it is a small clot, so I made a smile incision temporal to it, and retinectomy was done. The clot was retracted, but it was sitting right at the fovea, and after removing the extra blood from that particular clot, I just took it out with the forceps, and then it was very difficult to. I did few cases, and you can see that even the membrane has come along with the clot now. It was very difficult to cut this clot. In one of the cases, I even tried doing it with the frag, but it was not coming out in that way. There was a macular hole also in this case, so I did peel under PFCL. And then the laser was done to the retinal edges, and the case was closed. So in the second case also I did almost the same thing for the first part where subretinal TPA was given. I'll just show you the second part where it was even more challenging to remove the clot. The phaco was done and oil was removed. Then it was very adherent. In the previous case it was quite of lifted retina was there, so it was easier for me to make a smile incision and then do. But in this you can see it was just coming in bits and pieces. It was not coming like a proper lifting which I saw in the previous case. So I increased the smile incision in this case, but still it was not coming. Then I injected BSS using the same cannula 41 gauge to separate the retina here from the adherent clots beneath, and then it was getting lifted. Yeah, then similarly I just took out the clot, and the rest of the process was same. Then I filled it with PFCL and closed the case with oil. Thank you.
Okay, so yes.
In your first case, macular hole happened intraoperatively during
yes,
your
subretinal
injection.
When I was
TPA injection.
No, not TPA, sir. When I was removing the clot, the adherence
not during removal, during injection of your subretinal RTPA, the blowout, macular blowout happened. You see the video. In the first case, not while pulling the clot, during the injection of subretinal RTPA, the macular blowout happened. The foveal blowout happened.
Yes, it happened, sir. I have the OCT of the patient post the first surgery. There was no hole. When I took out the clot, then it was a slit-like opening which I saw after removing the clot.
Okay.
It was not the blowout. I was very precautious while doing it, and in one of the cases I had blowout in the first case. Then after this was the fourth case which I did.
But in your video, it was showing that is a foveal blowout happened. And second thing, while removing the CMEM, you have to use the fragmenter, just like using cutter for the nuclear fragmenter, as you use the fragmenter, to use the 100 cut rate and 600 suction in that setting. Even sometimes it's not coming out. Then only you have to take it out, just like ROB. You have to increase the schedule incision because with frag, the CNVM scar will not
come out. Sir. I know.
Actually, a slight modification in this. Right, one is the retinectomy. If it is in the periphery, it is easy for us to fold. And once we remove the clot, there is a foveal atrophy. I think it's very fond of RP transplant. So what we do is, after doing the RP transplant, there is a bare choroid.
Correct, sir.
So this plaque, which we are not able to remove, we remove all the blood, and just the fibrous plaque is, what we do is we fill it like a landfill there. That crater which was created by the RP transplant, you can put the retina back, maybe either in 2 stages or a single stage you can.
And what will be the location of taking the
choroidal usually so in this case you have made a temporal, no? Infratemporal or supratemporal is fine. I prefer
you have to do the retinectomy as close as to the oroserata, so that you don't have to do the cautery also. And second thing, you can take the graft from an area of relatively healthy looking RPA, because while removing the CNVM, you are removing the RP also. So that's why the bare part of the RP, which one left looking healthy, in that area only, you can take the full thickness RP choroid graft.
My question to...
And try to increase the retinectomy at least 180 degree, so that you can reach the macular area.
My question to sir, he did it in two steps. Why not the removal of the blood in the first step itself? That is my question. Because the more you delay the surgery, the chance of photoreceptor.
So the first surgery which I showed it, the clot was really big, sir, and it was moving. It was going beyond the nasal margin of the disc also. So I thought that I'll give the TPA. It will retract as it retracted in the second stage, which I showed in the video also.
I think I have
then
fundamental
it was
question.
easier for me to take out than rather than taking the entire clot in the first surgery.
Okay,
I
sir.
have a fundamental question. You injected TPA, but you didn't do anything to push the blood to the periphery. So oil is not the best option because
Right, sir.
it doesn't
It
have
is better
surface
with the
tension.
gas.
And you should have injected in such a huge clot, even subretinal air, that would have dispersed the blood quite well and put him prone with a gas inside the eye, not a full-filled gas, even a half-filled gas is
So
actually
I did
better.
partial SO filled along with some gas, sir. I did.
No, subretinal gas. What
Why you
Subretinal cocktail is what
getting a break intraoperatively in the first surgery?
No,
तो
sir.
partial oil का क्या logic है मतलब?
Sir, to displace once the air is gone, then the oil will also keep on displacing the clots.
नहीं वो तो कार्तिक है.
Yeah.
Oil will be less. It will float up, na?
Yes,
It
sir.
will not displace.
Just one point I wanted to add.
Did you inject anti-VEGF agents also? Because the cause of subretinal bleed.
Yes, I
This
injected.
is a mechanical thing.
In the
being
second
done.
stage, after a week of surgery, I injected anti-VEGF.
But personally, I think if such a large clot has to be evacuated and it is fibrosed also.
Yes, sir.
So what Dr. Nagpal does is in a vascular clot, it's very fleshy and it can be route through a small smiley. This smiley is very large. And you might as well go near the ora and make a good retinectomy and fold it
And
with the
then fold the
PFCL, and that
retina,
would be,
No,
making a large retinectomy such close to the posterior fold.
One thing is, in your first case, definitely anybody would have tried a subretinal TPA because it is beyond the arcades and which is indicated that to use the subretinal TPA in those cases. The only thing is I would have used gas instead of oil is because gas has the highest tamponading effect. It has around 70 dynes per centimeter square as compared to the silicone oil which has around 40 dynes per centimeter. So tamponading effect, displacement effect of the gas is definitely more high. That probably could have prevented the second operation. Because oil only stays there, or if you have used half, then it floats. It's lighter than water, it only floats. Aqueous keeps collecting down, so that will not give you any good effect other than any turbulence in the vitreous cavity. But we want turbulence underneath the retina here. The second case, what you did is absolutely right, because that was already an altered blood hemorrhage. Subretinal TPA will never work in case of altered hemorrhage. The only thing is, regarding the incision, definitely you could have gone little more periphery. The amount of C incision, smaller the incision, these kind of fibrous plaques will never come through the small incision.
Right, sir.
You have to make a little, see, if it is fresh blood, it molds.
Then it comes, yes, sir.
It molds through the smaller
It retracts
incision.
and come out.
Yeah, it molds and it comes out. But if it's already the altered fibrous plaque-like thing, then it will never come out. So that only causes an extension of the retinal tear. So rather than accidental having retinal tear in those cases, it's better to have an incremental kind of retinectomy. Try to see how much it comes, then increase your incision size. Thank you.
The only other point I would like to add is that when you're trying to induce a retinal detachment because you're having difficulty, you should have started inducing it in the periphery, where the retina is healthy and underlying RPE is good.
Yes.
But you are trying to elevate it over the blood clot.
Yeah, but it was very adherent. Right,
Then
sir.
the needle may actually go into the clot rather than between the retina and the clot.
Right, sir.
So
Long term, what happened to this patient?
Long term, they are stable, sir. So that is the OCT I was trying to show, but it was in the lieu of time not showing.
Yeah.
It is they are stable. They both are stable, and the vision is not much. It is 2/60, and in one of them it is almost 1/60. But yeah.
Good show, Dr. Kartika. We'll just need to move on for the sake of time. So
Thank you. Thank you, sir.
Dr. Arjun will be presenting next. Dr. Arjun, there's a video.
Good afternoon, everyone. At the outset, I'd like to thank Rupak sir and AIOS for letting me be a part of this prestigious symposium. I'll be talking about managing redetachments by injecting subretinal dye to find missed breaks. So the conventional approach to detachments where the break is not found or redetachments is make a drainage retinotomy, flatten the retina and do 360-degree lasers. The disadvantages of this are more laser leads to more inflammation and more risk of PVR, and you're unsure if the causative break has actually been addressed with this approach. So another alternative approach is to inject BBG subretinally and find the missed breaks. Let's see how this is done. This first case was a case with a giant retinal tear which I operated. He was doing well, and 1 month post silicone oil removal he came with this detachment. I couldn't find a causative break, so I decided to do a fluid air exchange. I go to the edges of the GRT with the fluid to see if there are any small breaks where I did the cryo, and I'm left with this bullous kind of detachment. So I make an inferior drainage retinotomy, and after this retinotomy is opened, under air I start to inject, but it's a bullous detachment with air, so it just keeps filling in there. I now shift to fluid, and under fluid I inject subretinal dye there, and you see there that the retina is getting blue and there's an egress of dye inferiorly anteriorly, and I go there with my flute needle, and you observe here that the retina is progressively flattening and it's progressively becoming less blue, indicating that there was an inferior break which caused this redetachment, and it was missed by me in the primary surgery. I now go back to the drainage retinotomy and I aspirate the remaining dye from the subretinal space, and now I'll start a fluid air exchange over the break, and I start the fluid air exchange, and as you see that the retina gets air filled, you notice there that there's an inferior break which was the cause of this redetachment. And now after that we just laser the drainage retinotomy and we laser the inferior break. No need to augment any additional laser, and silicone oil is being injected, and there again you see that lasered inferior break nicely, and this patient did well 3 months post oil removal after this surgery. This is another case which was operated elsewhere. He had an almost 360-degree laser done except in the superior nasal quadrant, and he came back with a redetachment post oil removal to me. I did what I did in the previous case, made a superior nasal DR and inject the dye. Here I'm using a diluted dye because I thought maybe this can cause toxicity, so you notice it's less blue, but I don't notice any egress except from the DR, and this detachment just keeps becoming more bullous at the site of the injection. I go with the flute needle, I try to aspirate the dye, I go in the periphery as well where the laser scars are to see if any dye is aspirated, but that does not happen. So I just go back to the drainage retinotomy here, and I go back again to a peripheral break, but there's no aspiration of dye. So I go back to the drainage retinotomy, flatten the retina and inject the dye like the conventional approach. So in this case, despite this technique, the break was not found by me. Thank you. And just to kickstart the discussion, I have some questions for the masters and panels.
Yeah, you can put it. Yeah, you can ask.
So the first question is, what would be your approach to deal with detachments or redetachments where you can't find the causative break? And the second one would be, does subretinal BBG dye injection have a role in your practice to find missed breaks? And would you modify this technique or apply it in your practice?
The first thing is that probably the inferior drainage retinotomy, what you did, I will not prefer not to do an inferior. So you have the option of the supratemporal also. So we'll have the superior, because superior break is always better to handle, and that is the only difference I think I can suggest. So any other
Incrementing cause you may not always find out, because I have not always succeeded to find this break. Like in second patient you could not. So then the only option is to make it flat and have a broad band of laser. Generally it happens in inferior detachments, shallow detachments, superiorly less likely, but inferior detachments then you laser. In fact, I remember one patient lasering till the arcade because I was not successful in locating the break. So from that previous buccal area till the arcade, I lasered that lady. That was the only option. But you did the right thing by in the first patient, you could identify, but it may not always work.
Right. See, Arjun, anyways, the missed break or recurring break is in the periphery, near the laser marks, near the chorioretinal adhesion. But you don't need the posterior pole to find that break. So might as well inject small amount of PFCL so that all the fluid egresses to the periphery, then inject BBG under fluid. It will be faster, it will be more accurate. So that is the only modification I would like to add to this.
Yes, PFCL, use of PFCL is a very nice option to detect the breaks in the periphery. Another thing, like, have you done the preoperative OCT in your second case to detect the macular hole?
No, sir. There was no macular hole.
Okay.
My question is to
I usually do
Purna
a
actually,
post-operative OCT
because
on
we
the
are
next day to
soaking
show
the
patient, so there was no
choroidal
hole.
space for such a long time with BBG. Even though we
Toxicity,
say it's not toxic, it will be really toxic. So have you done any ERG in this case?
That's what I was about to tell, but Vishal sir already covered that it is toxic. Okay, so sometimes when you inject and all that.
So that's why I diluted it for that
No,
second
no,
case.
whatever you dilute little, better to inject the PFCL. In my cases, whatever I've done, I always use the PFCL. In all my cases, the brake was opened up previously lasered brake. In all the leak was found near the brake. It is
Generally, breaks
toxic.
will happen
If you-
near that area.
If you remember that if when you use a dye, the ILM comes out easily. Without the dye, even if you're able to see the ILM, it doesn't come out easily. It tells you that the dye is doing something to the tissue. And however dilute it is, studies have clearly shown on cells, RP cells, that it is very damaging. So no dye, ICG of course is very toxic, even BBG dye, any dye for that matter is toxic. So never use it in the subretinal space, because you are really damaging the bed on which the retina is going to stay. So people have asked me this question for coloboma eyes, whether the communication between subretinal space and sub-ICM space, can you locate it? Yes, you can locate it. The video looks beautiful and all that, but in the process we are damaging the RPE quite a bit. So I don't think you should use a dye at all.
I was going to ask you the same question now.
Anything which is colored, it is toxic. It has color. Either if it's pink, blue. So if it's can stain some tissue, as sir rightly mentioned.
I think apart from the toxicity, what they are speaking about, yes, it's proved already. It's toxic, and electrophysiology probably might give you more results. In cases where you really ask where you use it, definitely in missed brakes or brakes where we're not found, we can use it, but only modification I would like to do here is use a 38 gauge needle. Because in your drainage retinotomy is so big that the fluid always can come out through that same drainage retinotomy where you are making. So it really becomes challenging to find the small missed break. So always you make a small retinotomies with 38 or 41 gauge needles and try to inject that. And secondly, as sir said, in colobomatous RDs, if you want to find is there a break in the intercalary membrane, although you know that there is no break in the intercalary, but putting that why you need to do it, because you might have to put a permanent oil in the cases where there are breaks in the intercalary membrane, or you might have to do a laser at the edge of the colobomatous area, but if it is skirting the macula, then that will not serve the purpose. So in those cases, you might have to use a permanent oil if there is a confirmed the break in the intercalary membrane. I think that was discussed in the last this thing also. So in those cases, you can use that, but definitely it doesn't give much of this thing. But the only thing is permanent oil in those cases, in the cases where there are breaks in the intercalary membrane.
No, I didn't get your point. Can you repeat it?
In case of colobomatous eyes, sir, colobomatous RDs, whether in the case where there is a locus resistentiae is given up, where there is a break in the intercalary membrane, and you are not finding a break in the periphery part of the detached part of the retina, in those cases, sometimes we do use diluted doses of 38 gauge needle, try to use a subretinal fluid where we can see that the break is in the intercalary membrane, because most of the times finding the break in the intercalary membranes in the colobomatous RDs is very, very difficult.
I would say that locating the break in the ICM is not important at all in the management, because here we are assuming that the whole coloboma is useless for us. And what we are aiming is segregating the coloboma from the rest of the retina and identifying the precise location of communication between subretinal and sub-ICM space is important if you are using gas as a tamponading agent, because it's going to only support the upper part. If you're using oil as a tamponading agent, even that is not very important, because very often you're treating the entire coloboma margin.
No,
I agree.
If it is skirting the macula.
Yeah, if it's skirting the macula, yes, what I would do at that stage is still try to treat at the edge of the macula and leaving the macula alone untreated with a half-burn treatment. Rest of it okay, rather than using a dye. I think to me, the dye is toxic and I don't want to use it in the subretinal space at all. And as ICM break location is not important. We're not going to support it, nor are we going to treat it.
Last point. Good idea. 38 gauge retinotomy. But the only flip side is that if you make a 38 gauge retinotomy and if you don't find the primary break, then you have created a iatrogenic RDA, because you will not find that to laser in the RDA.
Just a comment which I have done, I've diluted the blood and used instead of brilliant blue.
Dilute?
The blood. Blood with saline and then injected into the subretinal space. So that is less toxic, but then it's not that colorful. You will not be able to make out. But
What
then
about the clot?
Sorry?
Clotting and all.
Well, I diluted so much so that immediately take it, dilute it, and keep pushing it.
Even if you dilute, the thing is that color is blue, sir. It's a combination of light and the color. Both will act.
Look,
Because
follows,
blue is
yeah.
as such toxic, blue light. And this is
Yeah.
being close to the macula. Once the light interacts, it becomes even more this thing additive.
Yeah, for the sake of time, we'll move on to the next presenter. Probably the take-home message for the young people that yes, this is toxic. So even if you need to use specifically when you are not able to find out the break, that may be the indication. And with what he told, 38 or 40 gauge needle, so you don't need to make a large retinotomy, inject it with PFCL. So this is probably the take-home message for where you can, precisely you can use it for your advantage. We'll move on to next.
Sir, thank you, sir. Thank you, AOS and Rupak, sir, for the opportunity. So, it's a disclaimer before that, I'm not really sure this is an
59-year-old lady had undergone vitrectomy for post-cataract surgery endophthalmitis.
It's an innovation or
6
common
weeks
sense,
later,
you can
she
just do
presented with PL vision in her left eye with recurrence of infection. B-scan ultrasonography showed diffuse vitreous echoes and choroidal thickening. The plan was to do IOL explantation and vitreous lavage with silicone oil tamponade in view of hypotony. 25 gauge sclerotomy ports were made. Saline was injected using hard tip cannula to correct the hypotony. Retrolenticular exudates were removed using 26 gauge needle and the samples were collected. After ensuring infusion tip in the vitreous cavity, vitreous biopsy along with vitreous lavage was carried out. Intraocular lens was meticulously removed through superior sclerocorneal tunnel. Capsular remnants were carefully removed using intraocular forceps. Membranes over the ciliary process were visualized under indentation and carefully dissected and removed. The exudates over the peripheral retina was cleared. Inferior PI was done. Localized shallow RD was noted inferiorly and drainage retinotomy was done, followed by fluid air exchange. The detached retina was lasered and silicone oil tamponade was used. Post-operative vision improved to 615 and vitreous aspirate cytology revealed pythium isolate sensitive to linezolid. On follow-up, the patient received 4 doses of intravitreal antibiotics. This case highlights lens and capsular bag are the common source of infection which necessitates its complete removal. Accurate microbiological assessment is paramount. The membranes over the ciliary body and pars plana region should be radically removed and may often require silicone oil tamponade for hypotony.
Congratulations for the excellent outcome.
Very nice.
Sir, your opinion? This is a very common technique what we usually used to do.
That's why I told I'm not sure it's an innovation or in common sense.
No, that's okay. But again, for most of the time, whenever you are not sure about what it is, so probably why not the direct vitreous biopsy per se? Why you wanted specifically from that area?
No, this was a resurgery, sir. This is the end of underwent vitrectomy, recovered 6/9. They came with recurrent infection. Then obviously I suspected the capsular bag complex to the primary focus. That's why I wanted the sample directly to be, which is more representative of the infective foci. That's why I took it from the bag. Okay. Of course, I sent it from the vitreous also, but this pythium, this was isolated from the bag aspirate.
Okay.
The culprit was within the bag, like we have P. acne kind of infection. So there it is prudent to, if it is a recurrent, recurrent patient means you remove the IOL and remove the entire bag, and I generally fill up with silicone oil for 1 or 2 months.
And also I removed the ciliary membrane because I thought there is a ciliary shutdown which is causing the that hypotonia and all. If you don't handle this membrane at this, later it becomes like a plastic. You cannot peel also, no hypotonia. Luckily after that she recovered. That was
if this was the first surgery, what would you have done?
first surgery. I would not have peeled this.
If you are doing the first surgery,
sir?
what would you have in your approach?
I would not have explanted IOL only. I'll just do a vitrectomy. First surgery, usually I don't explain the IOL and back complex, even if it's a post-op cataract related end up. Only in the re-surgery, this thing. First surgery, usually I don't explant the back.
The first surgery, what I would have done, sir, was that I will make this capsulotomy and inject antibiotic within the bag.
Now we do that. So usually we do like intracameral and inside the bag and all.
It is important to have
Since it
the
was a
antibiotics reach
yes.
inside the bag. Because vitreous was quite clear. Vitreous
Vitreous
that was because the second surgery.
This was because second was all saline filled eye. Because first case only I induced the PVD and all that because it's a fairly simple case. First,
the entire brunt was within the bag itself.
Within the bag and peripheral retina and the pars plana.
Dr. Borrell.
Like, don't be too aggressive to remove all the capsular bags. Remove all the capsular, because most of the situation, in most of your fulminant situation, retroIOL membrane could be an extension of the cyclite membrane. And in your situation, in the inferior detachment happened during the removal of this capsular bag. Because they are indirectly inducing the cyclitic membrane to have a traction to the retinal detachment, because we have faced these are very dangerous cases.
No, the thing is, the inferior thing, it happened when I was trimming the pars plana membrane and all, but that's okay, sir. We don't mind, because the thing is, we are losing the eye for infection and hypotony. Yeah.
Because small people.
But it's true, sir. But you have seen the case of things. Sometimes we may win the infection based on long-term inflammation because of these are capsular crevices. The organisms could still be there.
The problem may be because most of them are small pupils. Even if you retract, you have to pull it with forceps. You can't keep doing capsulectomy because it's very difficult to have in a bound down pupil. I know, I understand what you are saying.
That's okay.
But the cause of recurrence was the IOL. That is agreed.
Yes,
you removed it. That is also good.
Exactly.
But the aggressiveness you showed in the base dissection was like a routine RD, and these are not routine cases.
Yes.
So the retina is boggy, and you don't see the periphery very clearly,
yes.
and you can create a break easily.
Yes.
Now, if you are injecting oil, all the exudates are anyways getting compartmentalized to the ciliary area, and it's very vascular. So it will resolve. You don't need to clear it on table.
Now, on table it was looking very fleshy and all that. One more thing was the ciliary shutdowns or hypotony. Unless you remove this membrane when they are fleshy and all that, ciliary body is not going to recover. And even if you win the infection, it's not. Which one? No, peripheral break that can happen wherever that. Yes, of course. If you are not careful, that can corrode. Everything can come. That is there. You have to be careful.
I have this question to everybody. Do you think a case which is having very bad retinal edema and necrotic areas and all that, you should be aggressive at the first instance and putting in oil just because you want to put oil, you want to shave the peripheral vitreous base and all that, or do a core, not exactly core, but a little more than a core vitrectomy, give antibiotics, and after a few days, go back inside, by which time the retinal edema will come down, the retina will probably behave better, and you won't induce too much of tearing of retina in the process. There you be aggressive, remove the entire vitreous base, and then put in oil. My approach would be that for a pseudomonas kind of infection or a bad fungal infection like aspergillus, where the retina is very, very necrotic, rather than trying to be very aggressive at stage 1. But this was the second surgery for him. Yes. That is fine. So that's what would be my approach.
Thank you. Well taken, sir. Any other? We'll move on to next presentation by Dr. Santosh Gopi Krishna.
Thank you, sir. Thanks for the opportunity. So it's a simple hack what I would be presenting. Not sure like many of you might be using it. So we obviously know how a moon is seen with less magnification and a higher magnification. You can see the craters and all. So I was talking about the hack wherein I use the wide angle, the central lens for a wide angle view. So this is how what I usually use, the Leica. We know that mini quad XL, what I regularly use, gives around 134 field of view, whereas the central super macula gives around 77 degree field of view. So and this is this comes to the biome wherein it's almost the same 120 and 60 degree. So what I here I usually do is I kind of, whenever I want to see a periphery, maybe it's an inferior periphery or something, I kind of move the eye inferiorly, and the assistant moves the supramacular lens in the opposite direction so that I can see the periphery of the retina. This is what I do. I've been doing this for years together for diabetic vitrectomy, especially where there are peripheral membranes. It's a short video. You can see that it's in the mini quad XL. There's a maximum zoom, and obviously it's difficult to focus with maximum zoom. And these are the peripheral membranes which have an extension almost till the ora. Now when you switch on to the supramacular lens, so this is the ideal view what we regularly see. We try to kind of focus on the central part of it, but this can be always used to even look at the periphery. So a little tilt, you can see those black artifacts appearing. So we can kind of maneuver around them, and we can see the edge of the retina. We can see the highlight attachment till the periphery. So this is a phakic lens. I have been using the left hand to kind of separate it. So then I switch over to the right hand. So finally I get a plane. It's a little bit of suction. There's already a tear there because of the subretinal bleed. So a little bit of suction and careful dissection. Obviously you can get across with this membrane dissection, and once that's done, then the job gets easy. So I find it really useful in this peripheral dissection, and even when in FAE or when I want to drain at the posterior pole, and even at the laser, when I kind of try to do laser at the posterior pole also, or even the mid periphery, I kind of use a supramacular lens and kind of get away with it. So this is just another case again. So these are young diabetics who had extensive neovascularization in the periphery. So initially I used to find it difficult to kind of focus with the supramacular lens, but once I got used to it, now I find it very comfortable to kind of use this, and it's a good hack, what I feel, to kind of peripherally dissect these membranes even with a supramacular lens. The only thing is we need a good assistant, a patient assistant. So I just feel it's an excellent hack. We can get a magnified view of the retinal periphery and a good control over 3D dissection without complications and breaks and without causing breaks. Endo laser, most of the times I use it in the supramacular lens alone till the mid periphery and beyond, and even to cauterize to most of the extent. Thank you so much.
Yeah, this is a good point for the peripheral visualization. Any comment? Yeah, Vishal.
Just not the surgical part. What happened was I used that for the slit lamp PRP and peripheral lattice laser. I was using quadrospheric. That broke. And I have the transequator lens for the macular laser. And I did not buy that. Now I'm used to doing PRP with that transequator lens. So if you tilt that, you can easily reach post equator. Not the aura, but easily past the equator. So that can be done. Very good video. Very good.
Just one point I would like to make.
Yes, sir.
Okay,
Sorry.
Go ahead. Go ahead, tell me.
No, I wanted to ask him, of course, there are variety of wide angle lenses there, because if I tell anything to Vishal and said, I don't want to talk about Ingenuity or 3D, he says. So not many, there are users of Ingenuity and 3D, so everybody will snub me. So I don't want to discuss. But since you are a, no, you are also a 3D user. So do you think that most of these lenses that enhances a little bit about the peripheral visualization with these existing lenses, any advantage of these 3D visualization techniques you see for the peripheral visualization?
Actually with 3D, when you do the fluid air exchange, we can see beyond the equator in these cases with the regular lenses. The moment we go to fluid, the air, I think we can, without any effort, just by depression, we can see up to the aura and beyond aura also.
Yeah. Just the magnified part, I think.
I think the important difference is that between a contact lens and a non-contact lens. Contact lens obviously gives you much higher resolution than a non-contact lens, because non-contact lens, the focus keeps on changing. The difference is exactly between 78 lens examination and the olden days contact lens examination. And the first lens of wide angle system was a contact lens made by Stanley Chang. It costed us nearly $10,000 in those days. and that was used to be handheld. So simple technique is to avoid the assistant holding it. What we were doing is suturing a lander's ring. A lander system ring is there, suture the ring, place this in that, and you can actually use one finger to just support it, and you can do it without the help of the assistant. That makes it easier. So I agree that contact lens always gives a higher resolution, no doubt about that. But yes, for ease and convenience, we use the non-contact biome. One question I wanted to ask you, the practical problem is how do you sterilize between cases? If you have 4 or 5 cases and you autoclave them, autoclaving is set to spoil the lens surface.
Yes.
If you ETO it, you cannot use it the same day again. So how do you manage it?
Usually we clean it and we put it in formalin, sir, between cases. Then
Not
again
acceptable.
we clean it and then we use it.
Not acceptable.
Yeah. So most of the time we usually keep it over the constellation table. We clean it, but we don't usually autoclave it so regularly between cases.
I don't think formalin is acceptable.
Then 4-5 sets also you need to have. Then 4-5 set you need to have to get prepared for that. Depends upon how many.
One case only.
ETO.
ETO. Only one.
Keep multiple lenses.
Yeah, that's what.
Otherwise you use biome.
But this is a very, idea which is there for since long time, that contact lens. But for the juniors, that yes, contact lens, you can use it for the periphery. Even if you have 1 or 2 sets, if you face like this kind of difficult situation, you can switch over to the contact lens and you can get away with this, even if you don't have the ingenuity or 3D visualization.
But this idea is wonderful, no? What LG was telling about the ring. You see, we suture that ring and put lens over it. Dependency on the assistant will not be.
Right, sir. That's more important.
Otherwise, it becomes very irritating.
Yeah, it's quite irritating, sir. Thank you, sir.
Yeah, thanks, Shantosh. We'll move on to our next speaker, Dr. Shivadarshan.
Yeah, I'd also like to thank Dr. Biswas sir and my master, Dr. Naresh Babu sir, for this opportunity today. So, slides. So, I'll be talking about a novel technique for resistance-free puff flow or carbon liquid delivery in intraretinal surgery, the air buffer PFCL injection technique. So, before I take you to the topic proper, I'd like to give credit to Dr. Chandy Chang because of his endeavors. I think we're able to use this liquid today. So conventional teaching is to turn off the infusion before injecting or using a dual bore cannula or pushing the light pipe in front of the jet to minimize this initial force or inserting a 25 gauge cannula through a 23 gauge sclerotic input. And all this is done to avoid a jet stream injury because of your high resistance PFCL injection. So the problem is high injection resistance, IOP imbalances because of the transient switching off of the infusion, uncontrolled delivery leading to subretinal PFCL migration and the jet stream injury. So what is the innovation? So we are going to include a small air bubble into the syringe proximal to the PFCL column before injection through the cannula with infusion still maintained as standard IOP. So load the syringe, draw the PFCL into the syringe and aspirate a small amount of air bubble proximally between the plunger and the PFCL column, keeping under standard IOP parameters, insert the cannula just like any other procedure and release and observe. So let us physics behind it. So this is the plunger here at this end and you have the air buffer zone in between and then you have the PFCL and then you have the cannula this side. So the air is compressible, it acts as a compressible cushion and it proportionally increases the pressure applied, smoothing out any pressure spikes during the injection, eliminating the sensation of resistance. And there's a pressure equilibration which develops inside the air PFCL cannula system. So here you can see the air is being aspirated in front of the column, the PFCL loaded. And this is something which we use in our center to differentiate between different liquids which we use, the anesthetic agent, the BSS or the PFCL. And once you tilt, automatically the air goes into the distal portion and you have the PFCL in the proximal end near the cannula system. So all you got to do is just aspirate 1 to 2 cc of air inside it. The small video is running. So you got to aspirate some air column in front, 1.5 to 2 cc. And you got the air, and then once you tilt, it goes behind. So what we actually see, the most remarkable event in this is the passive PFCL ingress into the vitreous cavity. This happens because of aerostatic head pressure, because of the PFCL and its high density, and you have a laminar flow dynamics in place because of the self-seal low friction conduit of the cannula system. So here you can see there's hardly any pressure being given to the plunger or very, very minuscule, and you have rampant movement of the PFCL in one go, and you can avoid all complications because of the high resistance faced by the routine conventional PFCL injection technique. So advantages, you have no resistance for injection, you have absolute IOP stability, your infusion is still on at 25 mm Hg throughout the entire injection process, you have controlled delivery, it's very ergonomic, very safe and reproducible across all surgeons. So in comparison, it's you hardly have any injection resistance, you have good IOP maintenance, and there's hardly any surgeon fatigue or hardly any force required for this at all, and there is no need for any additional equipment at all. So stable IOP gives you a good amount of patient safety. There's reduced turbulence, lowers risk of subretinal PFCL, predictable controlled delivery in all positions, simpler to teach all your trainees and junior colleagues. It reduces cognitive load during complex cases, reproducible across all experience levels. Air does not enter the vitreous cavity as PFCL flows ahead of it and the surgeon monitors the field directly. The technique does not alter the nature of the PFCL or the cannula used, and there's no additional surgical steps involved. So in conclusion, this technique, the air buffer PFCL injection, is very simple, safe and physics-grounded technique. Modification eliminates injection resistance, maintains IOP stability and enables passive self-regulated PFCL delivery. No extra equipment, reproducible, teachable, immediately adoptable with no learning curve, and there is sound physical rationale behind this. Thank you.
Two points I have.
Yes, sir. Yes, sir.
One is, of course, not connected exactly with the air buffer, but when you're using PFCL, the typical dual bore cannula is very nice for injecting, but very often if you are able to remove the PFCL, re-inject it, you cannot remove it into the same syringe, because when you suck back, saline also keeps coming in. So sometimes those days, that time I remove the dual bore, put a single bore cannula and suck out the PFCL, so I can reuse it in the same eye at the same time, because sometimes halfway through you need to remove the PFCL to do some maneuvers and put back PFCL. So you waste the entire PFCL if you use a dual bore cannula. That's incidental. About the air buffer, sounds like a good technique, but I just want to ask you, what is the risk that you are in and you are injecting, especially when the nurse gives you only 1 cc because she doesn't know how much you are going to use?
No, it's drawn by the surgeon, sir. We draw the air.
No, not air. I'm talking about the PFCL.
PFCL, yes.
And you inject some, but you want to inject more, and you have reached the end of your PFCL, then without your knowledge, you'll be injecting air.
Absolutely, absolutely. So I think in cases of RD, when you really require a large amount of PFCL, you be prepared, you take up at least 4 cc of PFCL. Unlike a TRD, wherein you just want to cover the posterior pole, probably 2 cc will be enough. So I think it's very important that you understand and you take what you need.
Yeah, and when I saw the video, I found that the jet still altering the retinal surface throughout your injection. Ideally, you inject the first bubble, the cannula goes into that bubble, and the bubble expands with no pressure on the retina at all.
So, but
that is the speed with which you inject.
Absolutely, correct. But then what we've seen here is this: the initial jet is again gravity dependent because of the compression of the air and not the PFCL
I'm not talking
itself.
the initial jet, subsequent injection.
Yes, yes. But that is passive. That is passive. Completely passive. There is no resistance from the plunger by the surgeon. There is no push required. It is automatic.
No,
it's automatic.
Is the room air you're taking?
Yes, sir. Yes.
That may have some issue. And secondly, it's always better to inject a small bubble and then, as he was saying, expand that bubble. Jet injury.
That is the conventional teaching.
Yeah,
yes.
But the point here, very elegant technique. But I just wanted to make myself clear: if you are injecting with air or without air, how would it not affect the IOP? It's not the ease of injection or the difficulty of injection which is increasing the IOP. It is the double infusion of PFCL as well as the fluid is on. So you said that because of less resistance, the IOP does not increase. But then the IOP increases because of the double volume of liquid in the eye. So how will it decrease the IOP with the air along with PFCL?
So rightly said, like routine cases, definitely you're going to have both your BSS as well as the PFCL going inside and causing the IOP rise. But here what I'm trying to say is that the PFCL is automatically ingressing into the eye. So no matter whether you're going to switch off or you're going to keep it on, it doesn't really alter the overall IOP. There is no dispersion related issues at all.
No, but why? The volume is the same. The infusion is on. Either if you are injecting with the automated infusion with the air in the PFCL.
I'm just trying to say that the teaching is sometimes as beginners you're being asked to stop PFCL, the BSS infusion while injecting PFCL. Here in this situation you don't have to do that.
Not infusion stoppage. You can reduce the IOP, but not without stoppage.
Correct.
Okay.
Thank you. For the sake of time, we'll just move on to next presenter, Dr. Ankur.
Very good afternoon to you all. So moving from the surgical, I'm just moving to slightly to bit and findings in mucormycosis. So during the epidemic of mucormycosis, we all was aware that mucor lead to CRAO, and every person that you see used to see retina having those cherry red spot was a CRAO. So what came to our mind was, when we are looking at these patients tend to develop endophthalmitis related to mucor. So we wanted to see what was happening and how it was happening. So we did a study, and for that, so this is, we all are aware that rhinovital mucormycosis is a highly morbid and rare disease. Recent literature has suggested that the retinal findings in this patient is secondary to CRAO in most of the cases. But however, the pathological findings have visualized mucor in the retina and have shown certain neutrophilic reaction. So it was pertinent that retinal inflammation secondary to the invading mucor had certain role in these microstructural changes. There were few anecdotal case reports about choroiditis, chorioretinitis, endophthalmitis with orbital mucormycosis, but however, most of the reports said it was a CRAO. So there was a need of this study. This was the lacune in the literature, and we wanted to compare it with the histopathology. So we designed a study which was prospective and observational in nature, which was carried out in our institute, that is in Delhi. 15 consecutive eyes were enrolled in this study having rhinovital mucormycosis. Outcome measures were retinal thickness, prevalence of data on SD-OCT features, and histopathological correlations. So all these patients recruited underwent standard treatment guidelines, and complete ophthalmic examination was done because these patients were admitted on weekly basis for 2 months. The central retinal macular thickness, the inner and outer retinal macular thickness, 1 mm nasal to the fovea was measured, and total retinal thickness was also measured, 1 mm nasal to the fovea. The patients with absolute loss of vision and loss of enhancement on orbital tissue on MRI underwent exenteration, and these cases were taken for histopathology. So what were the findings? The findings were that there were vitreous cells in these patients. There were vitreous debris, posterior hyaloid thickening, ill-defined optically empty spaces, hyperrefractive dots in the outer retina, and RP and focal RP disruption apart from the inner retinal thickness that we see. So if you look at this diagram, this is how these patients evolved. So initially you see the inner retinal hyperreflectivity, increase in thickness, which is quite suggestive of inner retinal ischemia because of the CRAO, but then it tends to open up. If you see those necrotic spaces in lower down, they tend to, you are seeing them and they tend to collapse, and there were vitreous cells in this if you see in the image on the up. Apart from that, histopathology suggested that there were mucor in the retina and the choroid. So what it tells us with time is that these changes that are happening in the retina were not only because of the angio invasion leading to CRAO, but there was mucormycosis leading inflammation in the eye. And how did mucor reach the eye? The mucor reached the eye through the peripapillary invasion, where the posterior scleral vessels reached the pierce the sclera. So these were the sites from where the potential infection and inflammation occur. So all the patients that you were seeing during that disease time were not CRAO. Some of them were evolving into endophthalmitis. So this study just told us that you need to look for that also. Certain patients could do well with intravitreal at that stage. Thank you. Intravitreal antibiotics.
Very nice analysis,
very nice,
sir.
Very nice observation. In fact, I don't think so I have studied this before. But as the infection resolved, you see the changes shifted from the inner infarction or the ischemia inner, then to outer some cyst formation, then ultimately near normalization.
No. None of these cases went back to near normalization.
Yeah. No, but the initial ischemia that resolved as the infection resolved, and then there was some cavitatory changes in the.
Yes.
Very nice observation.
Any comment? Yeah, again, the idea is it may not be an innovative things, but it is a new way of looking into the disease perspective into it. So, thank you, Dr. Ankur. Dr. Mohit could not reach here because of his flight was delayed. So, on his behalf, I'll just present. Can you just? Dr. Mohit will be, his presentation was intraoperative OCT guided minimally invasive subretinal biopsy for suspected vitreoretinal lymphoma. We have another 4 minutes to present, so let's. Yes, so after performing a thorough vitrectomy, he was, fluid air exchange was also being done simultaneously to complete the peripheral.
Entire vitrectomy is done on rear only.
Okay, yes. Triamcinolone to take out that posterior cortex. The main location of those subretinal mass was nasal side, where the intraoperative OCT was also actually focused on that area. Cauterization is being done. And with the soft tip cannula, you can just go inside. Parallel intraop OCT also is showing exactly whether you are into the subretinal space properly or not. Yeah, he has just introduced his little more into the subretinal space to get more amount of those lymphomatous material. Yes, so and laser was being done to the surrounding area. This is done under air, and this is the cytology was done, and the atypical lymphoid cells with diffuse large B cell lymphoma was there. Sir, you have done. I've seen you that subretinal biopsy also to do.
I think the role of intraoperative OCT is a little exaggerated in this case, in the sense that the OCT, you can either look at what you are operating upon, or you can look at the OCT image. You can't do both at the same time. We've got only two eyes focusing on one point. So you can't really switch between the OCT view and your operative view, because the OCT image is projected just above, somewhere here. So OCT is useful for you to stop, check where you are operating, and then surgery, and again go back to OCT if you wish to judge what you have done is correct or not. But I don't think intraoperative OCT guided is a better term than intraoperative OCT. Actually, you are doing it under a direct live OCT view. It is not so. And the other problem is the shadowing, because all the metal instruments produce severe shadowing. So I think intraoperative OCT in this case probably is an adjunct. I wouldn't say it is an absolute essentiality. You can still get the same material and cells without the intraoperative OCT.
Intraoperative OCT is not guiding the taking of biopsy. It's not guiding the taking.
Because you are able to see the yellowish material already.
Yes, so we just need to get some few tips from, if you have this lymphoma, so suppose if you have biopsy, so how to send the material so that they should not.
What he did first is all vitreous is collected under air. You don't use fluid infusion first.
Yes, yes.
So entire vitrectomy as much as possible is done under air. And after that, if you want to induce PVD, you re-infuse fluid now, and all that you have collected under air, you send it for cytology. Then you induce PVD and do whatever else is required. But the first specimen, most important thing is your prior speaking to the cytopathologist. And you should have a cytopathologist who is capable of interpreting cells. It is like showing a small OCT picture and with no fundus photograph, some of us have difficulty in identifying what it is, the lesion. The pathologist also has a difficulty in identifying that it's a lymphoma cell with only cells present and no background. So biopsy, they can interpret better, with tissue biopsy, but cellular biopsy, they have difficulty, unless he's an expert cytologist. So you need to send it to your cytologist, and specimen has to be transported immediately.
Exactly.
Because the cells lyse very quickly.
That's right.
You have to use very low cut rate, because the cells are very friable. If you use high cut rate, they will cut. So you use not more than 400 to 500 cuts per minute, not 10,000 cuts. And air infusion, and then collect the specimen. These are the precautions you should take. And have somebody waiting near the OT to take the specimen, rush it to cytopathologist immediately.
Exactly. This is, I burned my finger. I have sent to a pathology center which was almost 10 kilometers away. By the time it has reached there, by half an hour time only, it has been completely lysed. The cells were lysed. They have given the report of multiple lymphocytes seen. So lymphocyte does not give you the clue whether it is a lymphoma or not, though it is clinically. So, but the biopsy did not give me. So for the information, that's what I asked. Specific this question, that this has to be very well taken. If you need to talk to your cytologist first, make it ready. Once you are take it out, immediately send it to the cytologist. They can do a cell centrifugation, and accordingly they can take care of it.
I had the same incident. We transportation was slightly difficult, but the report came negative. They said no lymphotic cells. But that does not change our management still. See, I had a similar, initially we used to send it to Hyderabad also.
Okay.
With that pathologist there. So now we have a person in Gurgaon, but they claim themselves to be cytologists because they are used to have a lot of cell seeing. Occasional cell here, there they may not see. So negative report does not mean that.
It is. Yes, it is.
Because to collect the cells, you need to use the cytospin
Yes.
and collect the cells and then process them. You should also do for a MD88 mutation. So many things have to be done with the same specimen. Exactly. It should be distributed, and the pathologist should be able to look for MD88 mutation as well, mid-80.
Yeah, so you need to better prepare for handling those cells rather than the surgery per se. That was probably the message for this. So the time up is here. So thank you, Dr. Lingam Gopal and Dr. Lalit Verma sir, for writing the whole program, and all the masters here. So we'll have a group photograph of all the presenters, master with headmasters here. Please come.